Well, I've been introducing a lot of people saying that they were young, but now this next speaker is truly young in all aspects.
You didn't call me. Praveen, I have an objection.
You make everybody feel.
I didn't introduce you, Kumar, so you missed out. Well, you know what I think. Anyways, so we have Natasha Pahuja, who's going to be speaking up to us about dry eye and LASIK surgery. It's been subject to a lot of discussions that we've had in the last 2 hours. So hopefully she'll clear up a few things for us.
Thank you, Dr. Praveen, for that kind introduction. And thank you, ARC and Dr. Chitra, for this humbling opportunity. Hopefully, in the next 5 minutes, I'll do justice to one of the most common complications or side effects, as we call it, of refractive surgery, especially LASIK. Now, this was a WhatsApp consultation I had done for a colleague of mine. She sent me this image, a Placido image, and she said that after 3 months, the patient has come to me with no change in refraction, but the quality of vision and the lines have reduced. And she said, do you think it's post-LASIK ectasia? Because of lack of elevation data and epithelial mapping, I asked her, could you just send me a clinical image so that we can see the surface? And this is what we found. We found that the patient had severe dry eye disease. She had SPKs on the surface. So this is a very, very relevant topic, simply because more than half of our patients at the end of 6 months are suffering from or are not able to get the full benefit of LASIK simply because they're suffering from dry eye-like symptoms. Now, how do we deal with dry eye disease? It's actually very simple and it's stepwise. But most importantly, the first step is planning well, which is preoperative planning, also the intraoperative choices that we make, and how do we deal with it post-operative. Let's take it step by step. Preoperative, the first thing that we do is when a patient walks in and is interested in LASIK or refractive surgery, we give this questionnaire. Well, there are multiple questionnaires available. I personally use the OSDI and the SPEED questionnaire. It helps me decide if the patient needs a detailed examination and a detailed dry eye evaluation. So this is what the patient is further subjected to while the patient is, before the patient comes and sees me, even before the patient undergoes refraction. After getting a detailed dry eye assessment done, which includes getting the functional assessment, that means looking at the quality of the tear film, as well as the structure. Now, the quality can be determined by keratograph and the tear film interferometry. The anatomy or the meibomian gland structure can be determined by meibography, and there are various tools available to do it. So in a clinic, stepwise, what we do is plan it beforehand, see the patient very well, take a detailed history, and it has been done in this order. So after the questionnaires are determined, after which we see the patient on slit lamp without disrupting the ocular surface, the first thing that is done is the non-invasive diagnostic modalities, and then looking at the tear film composition in terms of osmolarity or checking the MMP9, after which we touch the ocular surface by doing either Schirmer's or T-Butt or staining the ocular surface. Further, we do a systemic workup for all our patients. And if we have the luxury of advanced diagnostics, we do look at the confocal microscopy and tear biomarkers. So essentially, it helps us decide in this multimodal disease as to where we stand. And especially the patient falls into the evaporative or the mixed type of dry eye disease, we do treat these patients preoperatively. Now, I've started doing IRPL for my patients. First 2 sittings go before they are considered for refractive surgery. And if the patient has got enough meibomian glands, I do consider doing the thermal pulsation as well. So after the patient is primed beforehand, then I consider refractive surgery. Now, the considerations that happen intraoperatively primarily is just one, which is deciding what kind of refractive surgery would you choose if a patient has already dry eye disease. Now, we know that there are denervation methods that happen. The less denervating methodology would be with the SMILE. Why is it so important is because the nerves on the cornea maintain the ocular surface homeostasis, which was also discussed earlier. And it is responsible for a lot of ocular surface disease pathophysiologies. So what we have documented is, and it has been published to death, that LASIK causes significant denervation immediately post-surgery, and it takes a few years for the nerves to grow back. So this was just me experimenting a little on one of the SMILE patients, and it was very encouraging to see that the nerves started regenerating 6 months post-surgery, which was very, very hopeful. And this also probably explains why the patients post-SMILE have less dry eye-like symptoms. And what was other factor that helps us decide is now the questionnaire that we ask the patient to fill up beforehand. This translated into a study that we saw that patients who had significant higher OSDI also had changes on the corneal nerves, as well as had increased dendritic cells. Now, this is a simple surrogate marker. You don't need a confocal microscopy to decide this. Now, if a patient has higher OSDI, we know that the patient is prone to have more changes post-denervation. Now, how did we translate this? Is that we started looking at the OSDI more in detail, and if patients who had higher OSDI, these patients, before they're picked up for refractive surgery, undergo vitamin D treatment. Now, this has been published to death again. We have looked at the role of vitamin D and dry eye disease, and it has seen in a clinical translation, we see that the patients do much better with vitamin D treatment preoperatively. Now, here's another perspective. While I was preparing this presentation, I came across patients, the neuroprotective role of citicoline, which has shown that instilling the drop 3 times a day has shown that the corneal sensitivity improves as early as 1 week, as opposed to the control group, which took about 3 weeks for the corneal sensations to come back post-LASIK. Now, this seemed quite encouraging, and I hopefully look forward to try this out in the clinic. While we are still waiting for it, and if you still decide to take the patient up for LASIK, here are some things that we would want to look at. These are patients who are at higher risk of developing post-LASIK dry eye disease. Asian race and female sex are known to have more dry eye disease. Other risk factors are higher refractive correction and higher ablation depth or thicker caps. The modification that we can do intraoperatively is that we can have wider flap hinges and probably place the flap hinge nasally rather than placing it superiorly if it suits your surgical style. These are certain factors which will help us decrease the incidence of dry eye disease post refractive surgery. Now, coming to managing post-operatively, how do we do it? Now, these are the possible mechanisms, and I just made a flow chart of it. The ideal way would be to tackle one of them. Now we know that there is decreased corneal sensitivity. So there is increased inflammation, because of which there is increased hyperosmolarity because the tear secretion has decreased. And there is increased apoptosis because of the ocular surface damage. Now, why not target these specific possible mechanisms? So what we do is essentially have post-operative medications that are targeting these specific etiopathogenesis of dry eye disease. For instance, for immunomodulation, we put the patients on cyclosporin for a longer time. The other promising drug is Zidra, which is yet to come into the Indian market. Autophagy induction would be very helpful, and this can be done by tear substitutes simply, Trehalose being one of them. And osmoprotective agents as tear substitutes would be very, very encouraging post-refractive surgery, post-LASIK. Other factors which can help decrease the incidence of dry eye disease is we know that meibomian glands do get affected in evaporative dry eye disease. So it would be important to tackle this post-operatively if the patient does develop dry eye symptoms, especially evaporative dry eye symptoms. So considering LipiFlow or in IRPL would be ideal to treat post-operative dry eye disease. Now, this is my cousin. He had a loss of meibomian glands. So I did pre-IPL. I mean, I had done IPL for him, and it was very encouraging to see certain meibomian glands coming back. I have absolutely no explanation why this happened. But after this, I did his refractive surgery, and he was very, very happy. So essentially, to sum up, this is my post-operative medication treatment modality that goes on. They have an exhaustive list that the patients are put at least for 6 months. So to summarize, it is important that we prepare well. It would be important that we do certain modifications for our patients to not develop severe dry eye-like symptoms, and most importantly, to choose are lubricants post-operatively that will reduce the incidence and the feeling or the sensations of dry eye-like symptoms that the patients experience. Thank you very much for your attention.
That was a wonderful talk, Natasha, wonderful. So much of information, and we didn't even have to give you warning at all that you were running late. That's the youngsters for us.
I just have one question, Natasha. The first case which you showed was very interesting, the topography.
Yes, sir.
So what did you do for that patient?
Actually, the patient was put on sodium hyaluronate, tear substitutes. I'm yet to see. This was a WhatsApp consultation that I did for a colleague. She sent me a Placido image. So I put her on sodium hyaluronate and gel-based formulations, and I'm yet to get a report back.
Okay, if you look at the topography, this is a very typical case. If you look at the topography and the staining pattern, this is a typical case of nocturnal lag of ophthalmos. And we see many of these patients who have a band of the SPK inferiorly. And if you look at the topography also, the topography pattern is typical of nocturnal lag of ophthalmos. And many a time we are looking at all other things, but we miss the lids. And what I tell the attendants is to observe these patients when they sleep at night, and then they don't close their eyes fully. So putting them on a gel at night and taping the lids, that improves the topography, and then the corneas clear up after a couple of days.
Yes. Absolutely. I should have mentioned earlier, sir. I just asked her to put those iPads. I said, when you use it in the airplane, just try and sleep with that. So probably it will be helpful. She was happy with it. But as I said, I'm yet to get a report back from the referring surgeon.
That is typical. I mean, if you look at the topography and the staining pattern, SPK, it's typical.
That was a very good observation, Sri Ganesh.